And now, without further ado, we are going to go ahead and get started with our program today. We are going to start with remarks from leadership representing the International AIDS Society, as well as the STI and HIV World Congress. They will be commenting on their commitment to better synergy and coordination of these two really important meetings as we move forward. As I mentioned earlier in my remarks, both these meetings happen concurrently on opposite ends of the world, so there was absolutely no way you could participate in both. And hopefully we'll be able to better align in the future so folks who want to do both of these important meetings can. But those are comments that I'm going to leave for, I'm going to stop sharing here, and I'm going to start by inviting from the HIV and STI World Congress, or the STI and HIV World Congress, Dr. Bobby Vanderpool, if you would like to make a few brief remarks. Thank you.
Good morning, everyone. This Congress several years ago added language saying STI and HIV World Congress because, in fact, it's the Congress of the International Society for STD Research. But we wanted to make sure that people were recognizing the fact that HIV is an STI, and of course, we do care about HIV control and effort and research. And so we wanted to make sure that the title had that inclusive portion to it. That said, the STI research world is still divergent from the HIV research world. And while we would like to really work to bring those back together and to reintegrate our research and our ability to offer services, these meetings remain separate, and it's been a struggle to schedule. And I'll just tell you, one of the things that we do when we schedule these meetings is we just, for example, chose and announced on our website our meeting site for 2027. So we plan 4 years in advance. In 2019, when I got the bid for Chicago, I did reach out to the IAS Secretariat at the time and asked about scheduling, and we actually moved our meeting by a week to try to avoid this mess, but we didn't avoid it at all. So, you know, the best laid plans of mice and men and researchers. So we do our best, but I think it's a small world, and I think travel dollars are going to become more and more restricted because people have decided, oh, all of my staff can attend virtually because that's what happened during COVID. Although I will say, I think there's nothing like the face-to-face interaction and ideas we get from one another through that networking. So while the meeting was a success, we all did miss the people that couldn't be with us in Chicago because they were committed to Brisbane. And I'm sure there are people in Brisbane that missed some of the people that were in Chicago. And so we would really like to find a way forward. One of the things that we're really discussing at ISSTDR, and I know that IAS is much larger than we are and so has different resources than we do, we are trying to find a way to provide hybrid and virtual solutions because we recognize the inequities of people in lower middle income countries not having access to participating and hearing the research firsthand. We couldn't afford to do it for Chicago. We talked about it for years. Couldn't make it happen. I know IAS was able to make it happen. So some people could have been in Chicago and then staying up all night long and watching things in Brisbane overnight. So if you're really super committed, you could have been in 2 places at once, Jim. But all that to say, I think that we're smart people. We can come up with solutions, and we just need to commit to doing it. And I really look forward to the fact that we're just talking about it in a large forum is such a huge step forward. I'm really grateful. So thanks, everybody.
Thank you so much for your comments, Bobby. And with that, I'm going to ask Mitchell Warren on behalf of IS to make some comments, please.
Great, thank you, Jim, and thank you, Bobby. And just to clarify, I still have a day job directing AVAC very happily. Unfortunately, no one from the IAS Secretariat was able to join the call given some travel issues, and some of them still actually in Australia. You know, for me, one of the I think we all look for good news these days in the midst of craziness, and perhaps the best news I've had in a long time really reflects the importance of how HIV and STI work comes together. And that was yesterday's announcement that Nyaradzo is the new leader of the National Institute of Allergy and Infectious Diseases. And it is so exciting because Jeannie has been a constant supporter of the IAS conferences, and she's also been a leader and actually led, I think, was it 6 years ago, Bobby, the ISS TDR meeting.
Yep.
And I think it's safe to say that if she'd been the head of NIAID a week ago, she would have wanted to be in both Brisbane and Chicago. And I think both conferences would have desperately wanted her to be a speaker. And the great news is I think there's a commitment from both ISS TDR and IAS. And I do sit on the governing council, and we did discuss this in Brisbane, making sure that the head of NIAID of the future, and none of us have to choose between the two. These are two critically important meetings. I am happy to say that IAS is meeting in 2025, and the location has not yet been selected, although it will be in Africa in 2025, the IAS science meeting. And I think as many of you know, the IAS has now announced a conference rotation system between the large International AIDS Conference, the smaller IAS science meeting, which was in the odd year, and then the HIV R4P meeting on prevention, which will go back to the even years. The next IAS science meeting will be in Africa. They're looking at the locations now, and they're looking at dates in June. So it would be separated from the ISS TDR meeting in 2025 by at least a month. And I think that's great news. I think it really reflects the desire by both organizations to create and curate programs and opportunities for all of us to be engaged. And I hope that Dr. Nyaradzo, soon Director Nyaradzo, is able to be in both of those meetings in 2025. And it really speaks to how these fields are connected. And I know that everyone on the call here is keen to get the insights of what happened in both of those meetings. And it was interesting to be I tried so hard. As some of you know, I pretend to be a travel agent some days. I tried every which way to be in both conferences, at least at some point. And it really is quite impossible to get between Australia and Chicago without several days. But the good news is when I was watching what was unfolding in both conferences, thanks to social media and amazing colleagues and commentators, it was really exciting to see that thematically there were so many commonalities. Obviously, both conferences has a huge amount of conversation about doxypep, just as one example. No one owns these agendas. We all co-create them. And I think what's important to me as an advocate and as someone working in this field is how do we make sure that these conversations happen in a strategic way, and how also they don't happen just for 4 days in a city because that's where a conference is. And I think we all know that on this call, and I know that that's a deep and abiding desire from both ISS TDR and IAS, that while the conferences happen and they happen in cities at a particular moment, it's all about how we take these conversations forward, which is why most of all, as important as both conferences were, and with all due respect to both ISS TDR and IAS, the important work is what happens today on this call and what happens on every day going forward to make sure that the conversations don't stop in a city because it hosted a conference, but rather they're catalyzing conversations that propel us forward together. So just want to thank you, Bobby, for being a partner in this and for the Choice Agenda, and Jim for bringing us all together in a conversation.
Thank you so much, Mitchell, and thanks again, Bobby, for those remarks.
Jim, can I add
Go ahead,
one last thing?
You may.
I think one of the things that we were considering from some of the activities that happened at ISS TDR and based on this conversation, I would suggest that we consider co-authoring, whether it's a position statement or whether it's an editorial that goes out to several of the major journals to say exactly what you just said. We don't co-own these ideas. We all need to move forward, and we can't just leave it in the city when we walk away. I mean, I think they're all super important points, and I think that having signatories from all the people hosting these meetings would just be a really powerful statement to the field.
Thank you so much, Bobby. At least 100 people have heard you today, and I think there's probably a lot of agreement there. Thanks again for joining us to make those remarks, both Bobby and Mitchell. And before I introduce Nyaradzo, someone had asked to remind them what's happening for our next TCA webinar. And we will share that when we send out the email as well, the follow-up email from this webinar. But on September 6th, There will be a TCA webinar focused on people who inject drugs, people who use and inject drugs, and how they fit or don't fit into both PrEP research and PrEP services and program. We can drop the link back into the chat if you would like to go ahead and register for that while you are here in this webinar. But without further ado, and hopefully recovering from jet lag, I am going to invite the wonderful Nyaradzo to the screen, who will be presenting to us from the University of Zimbabwe in Harare. Nyaradzo was one of the official tours the IAS conference in Brisbane, and so really looking forward to her talk. Go ahead, Nyaradzo.
Sure. Thank you, Jim. I hope you can hear me. Just confirm. I'm using two devices, and
We
I
sure
don't know
can.
if I don't know if my video is working, but anyhow, that's me on the picture, one of the pictures if the video is not working. So thank you so much, Jim, and the entire The Choice Agenda for inviting me to speak here. You can see my slides. Please confirm, Jim.
We can see them beautifully, Nyaradzo. Thank you.
Perfect. So let's try to move them. They are now stuck. Oh dear. Okay. My slides are not advanced. Oh dear. I think you're now seeing other things. Just a moment. Stop sharing. I'll restart. My apologies there.
No worries.
Point slideshow, this one. Are we good?
We see your open slide.
So I still cannot. Let's see, next. Okay, I'll have to use this option then. All righty. So thank you so much for inviting me to speak here. And thanks, Bobby and Mitchell, for the preamble. At least it puts everything in perspective. And I've never had such a difficult task to summarize a lot from a very good meeting, a very busy highly scientific meeting is IAS 2023. So trying to put everything into 10 minutes is going to be a very difficult task, but I'm just going to try the best that I can. And those colleagues who were there, you'll have to pitch in, especially during discussions, so that we talk about what really transpired. And I just want to give a shout out to my colleagues, because the summary I'm going to give is coming from Track C, the Epidemiology and Prevention Science, and I was the lead rapporteur with 3 colleagues, Catherine, Sky, and Richard. So really, I just want to acknowledge them. Some of these slides are from them. So what I gathered, the emerging themes, I'm just trying to summarize what came from IAS 2023, Track C, and the major themes that we gathered as rapporteurs was there was a lot of discussions on HIV elimination, so towards HIV elimination, and there was a lot of discussions on long-acting, highly efficacious long-acting injectable PrEP in treatment. And then there was a bit of discussion on colliding epidemics, COVID and HIV. And of course, we're here to talk about STIs. So I'll talk a bit about sexual reproductive health and the STIs. And at the end of the day, we must remember that whatever we do, whatever choices that we are giving to clients, to people, options, choices, they must be human-centered. There must be integration and differentiated services. So towards HIV elimination, oral abstract, late breaker oral abstract 6. From that, there was a summary that providing a social network approach to HIV testing could help reach the first 95 and contribute to the goal of eliminating HIV as a global threat. So that's just a summary take-home message from oral abstract 6, late breaker. So I'll start with oral abstract 1. I cannot see the title of my slide there because it's covered, but this is talking about HIV elimination. Are we there yet? So in this session, really, the focus was on indicators and metrics to determine progress with elimination of HIV. And this included the UNAIDS 95 targets in Australia. And we heard from Richard Gray, one of my rapporteurs, that we still have a long way to go to achieve targets in a range of settings. Yes, some countries and some regions like Eastern and Sub-Saharan Africa, we've done quite a lot. But Australia has achieved 91, 92, 98 in terms of meeting the targets. And the progress is ongoing, but it's not guaranteed. And then in this in this session, we also heard from Mula, who presented how unplanned treatment interruptions impacted mortality in South Africa. And this is coming from the IDEA SA cohort. And the summary or the conclusion from the studies that male gender, age, and lower baseline CD4 count, increased duration of interruption, and early interruption, they are associated with increased mortality. And then the next interesting topic was from Nakosa from South Africa by Ateni, who looked at high HIV incidence among people who inject drugs in South Africa. And what came from this study is that the province is the primary association for increased incidence risk. And we know that South Africa is heterogeneous, and we can see that incident cases were highest in Gauteng. So province really is the primary association for risk, and that syringe transfer programs and higher harm reduction packs, they tend to lower the risk of HIV. So there was also some other discussions, which I'll skip. And I've talked about the next slide. We're still talking about towards elimination in plenary session 5. So this session really, it focused on elimination of HIV through prevention programs, focusing on how we measure elimination, the progress with elimination at global, regional, and country levels, with a detailed examination of Australia and U equals U and HIV prevention. Excuse the cocks crowing from next door. U equals U and HIV prevention in the context of pregnancy and breastfeeding. So with zero risk of vertical transmission in the context of U equals U, what really is the role of neonatal PrEP? What are we telling women or people who do chest feeding, breastfeeding in terms of neonatal PrEP? If someone is suppressed virally suppressed before pregnancy, during pregnancy, and during breastfeeding or chest feeding, is there really need for neonatal PrEP? So a PEP, that was the question. So our duty is giving infants born to mothers living with HIV the greatest chance of HIV free survival, but we must not coerce women or people who chest feed into neonatal PrEP. They know the risks, but we need to adapt our guidelines, our counseling messages. And then there was also a study which looked at the benefits. This is Priscilla Pinto, who looked at the benefits of community-based primary healthcare programs at scale. And this was in Brazil, and it showed that Brazil's family health strategy had a substantial impact on AIDS incidence and mortality. So this primary healthcare-based program really works to reduce HIV and AIDS incidence. So even though we are still, some regions are still to reach the 95, 95, 95 goals, I liked this quote from Charles Dickens from A Tale of Two Cities. This is a tale from two cities or for two cities, but Charles Dickens says that nothing that we do is done in vain. I believe with all my soul that we shall see triumph and we will see the end of HIV come 2030. So there were many discussions on highly efficacious long-acting PrEP for treatment and for PrEP. One session that I liked was the discussion from Evie Parecki. She talked about, she stressed really that while resistance is a concern when we are using long-acting PrEP, it should not delay the rollout of such an efficacious intervention. And also she reminded us that the dapivirine ring really has a low resistance risk because of low systemic drug levels. And also there was talk about what type of test we should use when we are looking, should we use nucleic acid testing? Viral load coverage is not feasible in most countries because of the turnaround times and the costs. So there was, and I urge people to look at this session, highly, highly recommendable and in line with us rolling out long-acting efficacious efficacious interventions. And looking at this, still talking about long-acting PrEP, the symposium, the next symposium, Symposium 5, it focused on estimating HIV incidence for use in primary endpoint, as primary endpoint in clinical trials. Now that we've got highly efficacious CAB, what can we use as a comparator in clinical trials? So this was the discussion. We heard that conducting clinical trials in this era is of challenge, given that it is no longer ethical to use a placebo control, and we are using an active control, which is highly efficacious. So we need several approaches to estimating the background HIV incidence. We need to use a counterfactual placebo, and this was presented by Deborah Donnell, as well as Mupali Das, and Eugene from Uganda. So they talked about how we can estimate counterfactual placebo incidence rate using six methods, as you can see on the slide. And then there was talk about colliding epidemics, prevention of HIV and co-infections. We had a discussion from Joseph Puyat, who presented, whose presentation highlighted the potential need for flexible and adaptable guidelines for COVID vaccinations amongst people who inject drugs and those living with HIV, because they've got faster waning of vaccine effectiveness. Their studies showed that vaccine effectiveness wanes faster in people who are living with HIV. So they may need more frequent boosters. So that was the talk about the colliding epidemics. And then we heard from Claire Peterson, and congratulations to Claire. She described an intervention study of the integration of HIV PrEP services and assisted partner notification program in STI clinics in Malawi. So it was seen in this study, it was shown that women were more amenable to self-test rather than PrEP. So at least what was achieved from this study is that more women were more tested more, and partners were notified more. So this is the take-home message in this study. And then coming to human-centered approaches, we know that CAB-LA is acceptable for teens in Southern Africa, and this was discussed in oral abstract late breaker session number 6 by Sinead and other HPTN 084 team members, who talked about what young women like in terms of HIV prevention. So Okay, I'll skip this. So let's come back to the late breaker. So in this session, really this late breaker abstract session focused on factors related to oral and injectable PrEP use, such as confirmatory testing, user preferences, adherence disparities, and increased risk of other STIs. Data was presented from clinical trials and implementation studies of women women and men who have sex with men and transgender men. So here Sinead Delaney Moreche, she presented results related to the choices and preferences of women participants related to using injectable CAB or oral PrEP. And in this study, CAB was chosen by 78% of women in HP10 or 84, but there was a wide disparity of preferences and women were happy with their choice. So really we want to give women and other key populations choices and more options so that they can make their choice. What do they prefer? Is it about convenience? Is it about side effects? Is it because you don't like pills? Are you concerned about injection site reactions? And I won't spend much time on the presentation that I made on BNABs to prevent HIV infection. I reminded people or attendees about the AMP study, which was a proof of concept, which showed that HIV prevention is possible with one broadly neutralizing antibody, VRC01, but only VRC01 only protects against highly neutralization sensitive viruses. And in those neutralization sensitive viruses, prevention efficacy goes up to even 88%. And what we learned from the AMP studies is that future BNAB trials require a combination of antibodies or tri-specific antibodies, which are more potent with better coverage to improve overall prevention efficacy. I was going to play this animation, but in the interest of time, I'll skip it and then we can come back to it if there is more time. But why I put this slide on monoclonal antibodies, I just wanted to remind everyone that whatever we do, it must be a human rights-based approach. We shouldn't talk about equality. We shouldn't talk about equity. Rather, we should talk about justice. We should remove the causes of the inequity. Once we've removed the systemic barriers, then we can forge ahead, we can be successful. And I liked this First Nation, the Aboriginal proverb, which says respect for all and none and harm to none. It sums up what we do in GCP, in HSP, when we talk about justice, beneficence, and no harm. So respect for all and harm to none, according to the First Nation in Australia. So there was a lot of talk in terms of Jean-Michel Molina talked about the doxy PrEP. He talked about the short-term benefits of doxycycline PrEP among MSM. There's a strong reduction of syphilis and chlamydia, but impact on gonorrhea was limited. Doxy-PEP was well tolerated, but we are unsure of the long-term. There are some long-term uncertainties, so there's need for continued research. What about selection and clonal dissemination of more resistant STIs? So please go and look at that and absorb more. And also there was talk about integrating health services for diverse populations. There were good discussions on the PRIMA trial in Kenya, which discussed core factors of HIV self-testing and PrEP use among pregnant women. HIV self-testing in pregnant women was more acceptable than PrEP. And the HIV self-testing increased awareness of partners' HIV status from 4% to a whopping 82%. So this is a good paper for people to review. And also there's the IFECT-3 study in Thailand, which looked at hormone replacement therapy and pre-exposure prophylaxis, and there were no drug-drug interactions of major importance. So really, I've tried to rush through that, and I think my 10 minutes is way over. But yes, I just tried to pick a few interesting topics here and there. So I'll hand over back to you, Jim. Thank you.
Thank you, Nyaradzo. That was really beautifully done. And in the interest of time, I'm going to invite Roger to the floor to hear his perspectives from IAS, and then we'll see if there are IAS related questions before we move on to the two report backs from the STI World Congress. So Roger, would you like to go ahead and share your screen, introduce yourself and get going?
Hi, so I'm Roger Pebody, and I'm managing editor of AIDSmap.com. So let me just get my slideshow. Okay, yeah. I assume you can see that. Let me know if there's any problems. So I think there's a little bit of overlap between some of the things that Nyaradzo has already highlighted and the ones I'm going to put up, but I don't think too much. I'm mostly focused on prevention-orientated things, obviously, but I've tried to pick out a few other things from the conference that are just such big news that I think I'd be remiss not to mention them. I thought this was a really interesting study and something which I've been kind of waiting for over the last few months. As far as I know, this is the first time someone's done a decent qualitative study of men's experiences in the Mpox outbreak last year, and some of it was really quite difficult to hear. Talk about people having really quite extreme pain, and particularly really quite stigmatizing experiences with health services, pain not being managed, a lot of judgment around sexual behavior, and the traumatic experiences that you see that mentioned there. There's some treatment without consent. There's being isolated in a room. People likened it to being on an AIDS ward in the early 80s. And I think very interestingly also, a lot of people finding that, because there were follow-up interviews that were done several months later, that sometimes even a year after their experience or their acute experience, there was still ongoing impacts of having had Mpox. So that was one key study. And by the way, just to explain, I put up screenshots of the articles that we wrote on AIDSmap, which is the website that I work for, about those studies, and we can share the exact URLs to them later as well. The next one I want to talk about is a really interesting analysis from the PEPFAR program in Uganda about the impact on, particularly on the services that they had set up to be quite welcoming and quite friendly for key populations. And we're talking primarily here about men who have sex with men and what happened when that country debated and passed a Anti-Homosexuality Act, which really threatens human rights of men who have sex with men. And something that was particularly powerful was that not only was the country director for PEPFAR in Uganda actually presenting the data, but the US ambassador to Uganda, Natalie Brown, who's in the picture there, actually came to the platform to give really quite a clear message about the need for services to, the links between health and human rights, and the need for the services to actually reach the people who they are intended for, which are key populations. And that was, I must say, a level of political support I wasn't quite anticipating I was going to hear. And there was also some talk about some of the response, a number of the services about adapting home delivery of medication, increased security at clinics, doing more things over the phone or online, which has redressed some of the issues, but not all of them by any means at all. And this next study was on reproductive coercion. So this came out of the Stigma Index, and they looked particularly at 11 countries in sub-Saharan Africa and 5 in Eastern Europe and Central Asia. That's, I think it's Ukraine, Russia, and 3 of the Central Asian republics. And so you can see the percentages there. And actually, what I didn't put on the slide there is these are the proportion of women who reported these practices in the previous 12 months. So we're not talking here about lifetime experience. We're talking about very recent experiences of some really quite traumatic practices. And just to explain the different figures, the first figure is the percentage for Africa, and the second figure is the percentage for Eastern Europe and Central Asia. It was quite a simple presentation, but they already had highlighted that women who are members of key populations are much more likely to experience these coercive practices from their healthcare providers. So in terms of the really big stories from the conference, I mean, in my mind, and for the readership of our website, there are 3. And this is one of them, and I'm guessing a number of you will have picked up on this already. So WHO has put out a new, they call it a policy brief on essentially undetectable viral load and HIV transmission. And to some extent, the science behind this is relatively old, and some people's quite legitimate reactions like, haven't they already announced their support before? And I think they had indicated some support before, but perhaps they hadn't been quite so explicit in the language. I think there's 2 things that they did. They did a systematic review of transmission risks, and then they did a lot of work thinking about how to apply that message globally, and particularly in settings where kind of plasma blood tests that if you're in the States or Western Europe, you'll be quite familiar with that, what we are used to, where there are other types of ways that viral load is tested elsewhere. So the Lancet review, what they're really interested in is, because below 200, there's no need to review the data again. They did, and it came up with the same answer, 0 transmission. They're also interested in that sort of hinterland or the amber zone, say between 200 and 1,000. And so they really searched all the literature and could only find evidence of 2 transmission events around 600 and 800 copies per mil. So this is where their new language, that at this level, there is almost 0 risk of sexual transmission. So the word almost comes in, obviously, I think the original U equals U message was designed to be absolutely unambiguous and to have no negligible or almost or very extremely low or anything like that. But I think for the sake of being really accurate, that's the language that's come up. So just, this is the WHO's way of presenting risks. So a traffic light system starting on green, undetectable. And I think the point of this is particularly to try to give reassurance to people who are not testing with a plasma test. So if you're testing with a plasma test, you may well be told that your viral load is, say, 70, and then you can still know you're considered undetectable in terms of transmission. Or you might be told that it is not detected when it might be below 50 or something, for example. But the language here is now much clearer that if you're on a dried blood spot test or point of care test or anything, then if it says undetectable or target not detected, that you're good to go in terms of transmission or not having any transmission risk, excuse me. And so I touched on the amber category. I think in the States you might call it the yellow category. So this suppressed somewhere below 1,000. And I think, again, this helps clarify when people have had a test result that says something like, the language is something like detectable but not quantified, which is often quite hard for people to understand, which means they're not going to put a precise number on it. And those results would normally fall either in the amber or the green zone. And then red is obviously unsuppressed over 1,000. And that's clear that there is an ongoing risk of transmission. So moving on to something quite different. It was interesting, Nyaradzo picked up on a study from, I forget which country in sub-Saharan Africa, where that was asking PrEP users about their partners and then encouraging their partners to come in for PrEP themselves. And there were a few interesting studies really working on people's social connections. And this was one of them. And so this is a way of trying to reach men in fishing communities in Kenya. This is a really high prevalence area. Mobile men are classically considered hard to reach group, and really working with the connections between those men and having a really impressive impact on rates of HIV testing, and then also linkage to care if that's what's needed afterwards. I couldn't really talk to the choice agenda and not give you this one. So this was a relatively large study amongst trans women in 11 Asian countries, half had an unmet PrEP need, most of them because they'd heard about PrEP but had never accessed it. And the key thing, the big takeaway is cost is the key bit in a service that needs to be sorted out, and services need to be free. And that is what makes a PrEP service attractive overall. There's a number of other aspects, but cost is absolutely the first thing to sort out. There was an interesting cost effectiveness analysis about cabotegravir injectable PrEP. I'm not going to go into the weeds of these because they're so complex, but needless to say, the kind of prices that are being talked about for cabotegravir, around $250 a year, even on the voluntary license, seem to be way off what would be affordable for these two upper middle income countries. So never mind what's going to happen for a low income country. And listening to those last two presentations, which were on injectable PrEP, I was really led to think about, well, what about injectable ART? And that was just something I was trying to work out myself at the conference. There didn't seem to be much a realistic discussion about getting injectable ART outside of high income countries. And I mean, I have a read of the piece. My sense is the prospects for this are quite limited, particularly there are two drugs in there. One of them, there doesn't seem to be any clear plans about producing it generically. And it also seems to not fit in very well with the way that treatment guidelines are written in terms of trying to find the optimal solution for the maximum number of people. And I just thought that quite ironic talking to the choice agenda, whereas there was actually a discussion in one session about how important is choice in ART programs primarily in sub-Saharan Africa. And the speaker who said that actually, we need the best one-size-fits-all solution actually won over more people in the room than the advocate who was arguing for choice. Last few things, statins. This was obviously this is not prevention or prevention of HIV. story, but this is absolutely the most important clinical story that came up. So this was results from the Reprieve trial, which was a really large RCT looking at whether people with HIV in middle age who are low to moderate risk of cardiovascular disease, so wouldn't normally be prescribed a statin, whether there was benefit, and there was quite clear benefit. So this is probably going to lead to some guideline changes. And I think it's interesting thing here for me is I think normally when you read about statins in the media, they're described as something that lowers cholesterol, and it looks very much like they also have anti-inflammatory effects, which are quite important for people with chronic HIV infection, which is part probably of what drives high risks of cardiovascular disease. So it was a key study there. And just to point out, there was a whole bunch of things about cardiovascular health. I don't think I've got time to go into those, but there's plenty on that broad topic. And this is the last thing I want to present. And this is probably the other big story that you would have picked up on from the media. Although interestingly, I thought there was less media attention to this probable case of HIV remission than there has been to the other 5 that we've seen before, which is interesting. It might be something we can talk about in the discussion about what has the media decided that, well, when we know that happens now, so we're not interested. There is something really novel in the details of this case, which I think there's probably other people on this call who are much better qualified than I am to explain that. But yeah, if you didn't hear about this, perhaps because the media didn't talk about it so widely, it's probably something you might. And I think that is pretty much all from me. And thank you.
Thank you so much, Roger. And I'm going to invite you to stop sharing your screen. Thank Nyaradzo as well. And we're going to see if there's a couple of quick follow-up questions. I know that Anu has a question. Anu, if you'd like to come online and ask your question regarding U equals U.
Yeah, thanks both Nyaradzo and Roger for those awesome updates for someone who wasn't able to go to IS. I had a question about the U equals U. So I know from the WHO graphic, it sounds like the undetectable is defined by lab tests. And I was just curious if they had any reasoning behind that when when all the partner data and all that was using the threshold of less than 200. I only ask as a clinician because I have several patients who get nervous with virological blips of no much significance up to like maybe 30 or 40. And based on this guidance from the CDC, from the WHO, that technically wouldn't be considered undetectable based on their definition.
Yeah, I think if you look at the systematic review, and to be honest, this data has been around for several years, all of the key studies which looked at, which kind of basically provided the evidence for U equals U, they actually used a threshold of under 200. So, I think my interpretation of that is, okay, if the lab test happens to have a threshold of 50 and someone's undetectable on that, absolutely, that's clearly undetectable. But, if someone has a blip, if someone even rises to 170, 180, for the purposes of this, they are undetectable in terms of transmission risk. And the WHO has clearly given their support to that. And also for somebody who gets their undetectable result from a dried blood spot test, for example, that they would also be considered to have no transmission risk.
Okay, all right. Yeah, just wanted to clarify that 200 was still a threshold for what the WHO considered to be undetectable and untransmissible risk.
To be fair, they are avoiding using numbers around there. They're deliberately saying whatever the test is, if it's a valid test that is WHO pre-qualified, and I assume something that is FDA approved in the States, whatever would also be, then if it's not detected, you're good.
Okay. All right.
Thank you for that question, and thank you, Roger. Roger, I also had sort of the same. When that came out, I was scratching my head like, what have I missed? I thought this was something we've known about for years, but I appreciate the diving into the nuances here and what the WHO is trying to do. So thank you for that. Do we have one more question for Nyaradzo or Roger regarding IAS? You can raise your hand and we'll hear from you. Otherwise, we can move on and we can check back when our STI presenters are finished, or our Chicago presenters. Okay, so we're going to keep motoring on. I'm going to now invite to the virtual stage Charlie Peterson from the University of Illinois, Chicago, who will be reporting back on the things he found interesting at the STI HIV World Congress that took place last week as well. So go ahead, Charlie.
All right, thanks a lot, Jim. Can you see my slides all right? You can hear me fine?
Yes, everything looks great.
All right, great. So my name's Charlie. I use he, him pronouns. I'm going to talk about community advocacy and implementation updates. This year's theme was local engagement and global impact. When you look at all the presentations, the categories that kind of stood out to me were DEI, strengthening communities, innovation and implementation, and care improvement. For DEI, there are some things we always need to consider. You need to approach key communities with respect, intentionality, and purpose. Recognize that when you're in people's communities, that's their safe space. If you're in their organizations, their parks, that's where they live, that's where they exist. Be mindful of that. Acknowledge intersectionalities, social inequities of health, traumas that people have, different lived experiences. Know that everybody, all of us, are looking for inclusive healthcare. You want to feel seen, you want to feel understood, you want your needs met, you want your lived experiences affirmed, right? We also heard a lot that diversified community stakeholders provide many perspectives into and critical knowledge, because they live it, of key populations, thereby increasing the quality of healthcare initiatives. You hear all the time, I'm not a finger prick, I'm not a checkbox, I am more than a number. So in healthcare settings, you want to be seen, you want to notice inclusion from allies, organizations, and people who come from our communities. It helps inspire trust in the medical and research communities. So Joe Tucker from UNC at Chapel Hill talked about pay it forward models in Asia, and I thought they were pretty neat. They increase community connectedness. They help pay for the costs of STI tests. And we know from scientific behavioral studies that kindness begets kindness. So these are receive, give models. You receive a free healthcare service, and then you donate in kind. You either write a message on a postcard to encourage people, hey, get tested, I did this and it's wonderful, or you give money. Jagadisha Devashree Dekas from Northwestern's Institute for Sexual and Gender Minority Health discussed key population-led approaches, where these approaches are identified by the communities themselves, making them needs-based, demand-driven, client-centered, and they're co-created between communities and public health agencies, which makes them kind of done in a checks and balances system. Also, because it's done by the communities, it's offering stigma and discrimination-free comprehensive services, and you can place them in areas of high need. I'd like to state that key populations should be involved in the ideation of things, implementation, provision of service, analysis of data, modification of approaches if needed, and the dissemination of results and outcomes analyses. One thing that stood out to me was this transgender woman advocate, Reina Janam Nuesuk. She wanted a shift in the paradigm from community engagement to community leadership, which can be applied to STIs as well. Key populations can't only be service recipients. We don't want this just to be community driven. We want it to be community led. It's a key piece, which is why there's that piece in red there. We heard about education of community and advocates on the importance of testing, different options available to people. The armamentarium is key, and the pipeline. Also, use trauma-informed approaches when serving marginalized communities. Greater visibility of messaging helps others take STIs seriously. You've got to focus on the population at large. It reduces stigma. It normalizes talking about STIs. As you hear it more, you see it more, it's repeated, you learn it, you become, you live it, right? Additionally, STIs don't live in silos. So why does HIV and STIs? There's a call to blend approaches. We've already heard that. If you work on STIs, work in HIV and vice versa. Following that, the HIV model of incorporating community voice and in messaging and advocacy is key. You've got to get community members to planning councils. That gives greater voice, but you have to make them talk when they're invited to the table. And you have to help make sure that people listen to them. Adding community input into clinical research ensures that studies are inclusive. Have them look at trial designs, protocols, ICFs. Make sure that target populations are inclusive, right? Innovation and implementation. The current system puts nearly all of the burden on the clinical healthcare system, and we're looking at a paradigmatic shift, a decentralization of sorts towards self-testing and artificial intelligence applications like screening tools, chatbots. And this is basically from COVID-19. We saw a lot of home tests, and STIs are just kind of picking up on that, which I think is very smart. These self-testing kits can be available anywhere, right? They can be at drugstores. In Kenya, there was a discussion at the conference. They're in pharmacies. One Congress attendee was mentioning that you can find home testing kits in vending machines outside her hospital's emergency department. They can be at supermarkets. You can buy them online. This essentially enhances discretion. It increases availability. These kits are in locations open enough to not arouse suspicion. If you're seeing someone can't go, ooh, I know you're getting an STI test. Joseph Sharabi from Washington University in St. Louis highlighted benefits of self-testing. They're convenient. More than 50% of their patients preferred home testing kits, and that was completely irrespective of insurance status. You get fast results, you minimize person-to-person interaction, which can reduce stigma. It can be less time-consuming. It increases screening rates. Also, you can bypass some systemic barriers, right? If there's a digital divide because of socioeconomic status, no internet, computer, phone, you can bypass that. Travel concerns, you don't have a car, public transportation is difficult, gasoline is expensive, there you go. You can also target these and put them in areas of greater need, which can also lead to telehealth. We've got remote options. We need to think about that when you're in areas where same-sex relations are criminalized or stigma is heavy. This is definitely key. There was a Preventex presentation that showed that home testing led to the diagnosis of a similar number of STI infections as would have been seen in clinics. Let that sink in. There's a lot of accuracy there. Home testing kits were also being ordered a lot, to the order of about 2.2 million kits, with a really amazingly high return rate of about 1.8 million. So the takeaway here is more options allow for greater reach, allow for more testing and more diagnoses. Gives us a trickle up effect. There's more testing, there's more data collection that goes up to us, and we can make better informed decisions. Lee Zhang from the Melbourne Sexual Health Center and Udara Kularatne were speaking about AI screening tools. You can use them on the phone and take pictures of your hoo-has. Platforms here, they're confidential, they're private. You can use them from your mobile devices. They've got pretty good accuracy, 71% and onwards, depending on what you're looking at. AI, it continually learns as there's more data in the systems. eHealth actually will help deliver you personalized instructions based on local guidelines. And I thought that was pretty amazing. I want to say though, these databases don't adequately represent marginalized communities. eHealth, when you take a picture, it doesn't recognize conditions as well. Brown skin. Professor Claudia Estcourt from Caledonian University also reminded us of the great digital divide. So, just make sure that you're helping to minimize any kind of systemic barriers. Chatbots are also an option in AI, and they can be used for initial conversations with clients. Planned Parenthood has Rue over here, who's pretty cute. The bot can talk about sexual health, relationships, growing up. Bots can also be used to reach marginalized communities. There's no judgment. There's no stigma. It's a robot. It offers a safe space to discuss private, vulnerable topics for people who might be sensitive talking face-to-face to someone else. And they can provide relevant and personal answers, as Tom Nadarzynsky from the University of Westminster mentioned. The cons, right? The digital divide we've talked about. It's not a human. It's not diagnostic. It's talking about signs and symptoms or answering simple questions. It's also only accurate if the human is providing honest answers. Then we talk about care improvement, right? Theodora Wee from the WHO kept stressing the importance about being open about speaking about sex. We have to recognize that people are sexual beings. She called for integration of STI services with primary care, sexual reproductive health, and HIV. You got to make people feel more comfortable about talking about STIs. That's why we have to talk about it a lot more, and facilitate point of care diagnostics and other affordable technologies. The key is affordable. People in general need to be able to afford this. And then finally, STI testing should be targeted. I'm not going to go into all of those, but underinsured, uninsured, rural is huge. Also, making STI and HIV tests at emergency departments opt out. It's already on the list. It's going to be done unless you say you don't want it. You have to acknowledge the traumas that lead to current medical distrust so that you don't sound tone deaf. You need to see people. Recognize also that healthcare is not necessarily a priority for people, especially when they live paycheck to paycheck. They have to take time out from work. They have to commute. They have to pay for transportation potentially. Then they have to pay for the visit, the medication, a follow-up. It can be expensive and very time consuming. So you need to recognize that. Also, communities need ambassadors and additional education. So that's always part of our purview. The community group Designathon wanted a repositioning from a more negative risk-based messaging to positive, right? Sexual pleasure, sexual health, sex normalization, and sex positivity. We're all doing it. We're doing it with ourselves. We're doing it with a person. We're doing it with more than one person. We're doing it with things. Sex happens all the time. And that is my coverage of this Congress. Thank you so much.
Beautifully done, Charlie. Thank you so much. So much great stuff to dig into, and thank you for highlighting all of that. I'm now going to ask our final speaker to bring up the rear and share their perspectives from the conference. Dr. Anu Hazra with the University of Chicago and Howard Brown Health here in Chicago. Go ahead, Anu.
Awesome. Thanks, Jim. I'll try to keep things brief so we have some time for questions at the end too. And so I'm going to give some more clinical and biomedical updates to complement what Charlie just said. So yeah, we can start with some new information on Mycoplasma genitalium, which I thought was really interesting, trying to find sort of newer antibiotics or better antibiotics potentially to treat. So we know Mycoplasma genitalium is no longer an emerging STI, it's sort of here, and it's a cause of non-gonocolic urethritis. And we have many classes of antimicrobials that can be used for MGen. And we know that macrolide resistance, so we often, for the longest time, we're really weighing heavily on azithromycin, but we know that resistance to azithromycin can exceed 50% to a lot of places globally. And we're already seeing fluoroquinolone resistance against ciprofloxacin or levofloxacin or even moxifloxacin in a lot of parts of Asia and the Pacific. And so there's really a need to think about alternatives to quinolones if they fail or are contraindicated for several reasons. So minocycline is a tetracycline. I think of it as a cousin to doxy. And there's limited data that shows the efficacy of minocycline in treating MGen. And so this was looking specifically in Melbourne, a retrospective review of macrolide resistant Mycoplasma genitalium between February 2020 and May 2022. And they defined cure, so the folks who were cured of MGen with a test of cure that was negative within 14 to 90 days after completing their minocycline course. course. And so this is sort of how their participant selection. So out of 90 patients, 60 experienced microbiological cure within 14 to 90 days after completing minocycline. And minocycline was dosed as a 14-day regimen of 100 milligrams of minocycline given twice a day. It was well tolerated with very minimal side effects. And essentially what they found was minocycline was a non-quinolone alternative that will cure at least 2/3 of macrolide resistant infections. So again, just gives us another tool to think about if you have people with persistent MGen who haven't been cleared after our usual therapy, which is currently recommended as a week of doxycycline followed by a week of moxifloxacin. There are some new updates on pratelivir for resistant HSV. So again, we see specifically immunocompromised folks high rates of acyclovir resistant HSV. Up to a fourth of cases in immunocompromised folks will be resistant to cyclovir. And really the only therapy available to those people who are resistant to cyclovir is IV foscarnet, which is highly toxic and often requires really close monitoring and is IV, as you can see. And so there is a huge need to think about other potential agents that can be used for resistant HSV. And so pratelivir is has a novel mechanism of action inhibiting sort of viral helicase and primase complex, and has already gone through phase 1 and 2 trials. And so in the phase 2 studies showed that pratelivir reduced viral shedding and clinical lesions and demonstrated superiority to valacyclovir in suppression of HSV shedding. And so we potentially have a superior drug to valacyclovir specifically in immunocompromised patients. So again, I think it's pretty exciting. There hasn't been a lot of movement in the field of HSV treatment in quite some time. And I think the more that we can think about novel approaches to HSV treatment, as well as advancing HSV diagnostics, is hugely important to the field. They also presented how they plan to proceed with their phase 3, which is ongoing currently, and they'll be actually comparing pratelivir to foscarnet, which I think will be really exciting to get that information. If it shows to be superior to foscarnet, I think that will be a really great game changer and really practice-changing recommendation to think about how we think about acyclovir resistant HSV, not only in immunocompromised hosts but potentially in immunocompetent folks as well. The folks from the Massachusetts Department of Public Health presented their data. So folks who've been following or may have been aware, Massachusetts identified 2 novel multi-drug non-susceptible Neisseria gonorrhea cases in late 2022, early 2023. And again, the identification of these 2 non-susceptible cases prompted the DPH to broaden surveillance across the state. Just a little information about the 2 cases identified in Massachusetts. This is the first time we've seen a multi-drug non-susceptible gonorrhea in mainland United States. Again, the first case was in a patient who presented to primary care with dysuria and no known STI exposure and performed gonorrhea testing via urine culture and a NAT. And then the second case, and then per state regulation, they found the MICs were demonstrated to be resistant and reduced susceptibility to all currently recommended drugs for treatment. And the second case was a result of enhanced surveillance following the first case. And again, they collaborated with laboratories in the CDC to undertake retrospective molecular analysis of remnant and NAT tests that that patient had. And based on the genomic analysis, it had similar to reduced susceptibility to ceftriaxone and cefixime, which was obviously very concerning. And so what they did was implement enhanced surveillance across the state, which was to perform gynecological culture and from genital and extragenital sites of all symptomatic folks, in addition to routine NAT tests, obtain risk history, including travel history for all gonorrhea positive cases, and perform test of cure using NAT or culture 14 days after initial treatment at all previously positive mucosal sites. And then also perform tests of reinfection with NAT within 3 months after therapy for patients previously treated for gonorrhea. Again, you can imagine this is a massive undertaking, a lot more sort of diagnostics and treatment that is required during this time. And between January 19th, when this enhanced surveillance began, to May 18th, about 224 cases of positive gonorrhea cultures were reported to the Mass DPH. This is looking at, again, the cases with only NAT versus the cases with positive culture. And they show that it was men and non-Hispanic white men were significantly higher in terms of their case report. They were able to actually look at a number of isolates and looking at the antibiogram or resistance testing of these isolates. And they found that actually the majority of isolates were still 100% susceptible to our common antibiotics, but there was a drop in susceptibility to ciprofloxacin, which is, one of our fluoroquinolones that we have used in the past to treat gonorrhea. And so what they found is since the critical alert in January 2023, culture positive symptomatic gonorrhea cases were distributed across the state and largely represented male individuals residing in moderately high or highly vulnerable census tracts and geographically in the state. The majority of these culture positive cases were reported by ID clinics, sexual health clinics, and ER urgent cares. And the number and gender of sexual partners and travel history were inconsistently documented, so we don't have great data to look at that. And what was reassuring was at least susceptibility testing revealed significant ciprofloxacin resistance, but no further cephalosporin, macrolide, or aminoglycoside resistance. So that was at least reassuring to the DPH, but again, seeing sort of significant cipro resistance from their enhanced surveillance. There was some really cool stuff on AI done for folks who went to the conference, looking at AI and bots, and Charlie, I think, touched upon a little bit of this already. There was a few folks that presented their AI tools in diagnosing and thinking about STI screening. And again, this was one that was presented looking again at their sort of algorithm of how they've been looking at collecting lesion images, then labeling the diagnosis by clinician, teaching their AI model of what that looks like, and then seeing what the AI model comes up with. And what they found was when compared to ID and sexual health doctors, their AI model achieved about a 71 to 83% accuracy and has been improving. And these were the diagnoses that the tool was helping to identify. I will say the majority of all of these pictures and cases all came from male bodies. And so I think there's still a lot of work to be done on female bodies or on vulva and intravulval lesions that they were not able to really use this model for. So definitely a lot of room for improvement, but I think something that will likely impact our sexual health and STI field in the future. And then lastly, we can't talk about STIs without talking about doxy-PEP these days. So Janelle Stewart from University of Washington was there's actually a really good question in the chat asking about the AI study and racial and skin tone diversity. That question was asked by folks, and it looks like no, that there was not a lot of racial skin tone diversity, and that is also another major impact that or a major area that these AI tools need to really address. So going back to doxy-PEP, so Janelle Stewart at University of Washington sort of expanded on the results that she presented at CROI earlier this year at their negative study of doxy-PEP in cisgender women. So again, doxy-PEP was found not to reduce incident STIs amongst cisgender women in Kenya. Again, they raised a lot of questions that, there were a lot of similar HIV PrEP studies done over a decade ago that also had similar negative results, but often was found to have lack of efficacy due to adherence. And actually, Jeanine Mazzarno, we just talked about, the new director of NIAID, presented great data at CROI showing that when you compensated for this adherence difference, there actually was no difference in PrEP efficacy among cisgender women in sub-Saharan Africa and other parts of the world. And so really a lot of the data that we have initially about PrEP not being working in cisgender women was really around sort of adherence than anything else. So in general, the women who were participants of the study were brought back each quarter and questioned, when they had sex and if they used doxy-PEP or not. And so based on self-reported adherence, 77% said they had coverage over their last sexual exposure, meaning their last sexual exposure they did take doxy for. In 72% of the quarterly surveys, nearly 80% said they had their sexual acts covered. And 64% participants reported full coverage at least 80% of the weeks of duration of the study. And 78% of the weekly SMS reports did report full coverage with doxy-PEP as well. However, when they actually started doing hair drug testing of doxycycline metabolites in the hair, they looked at a subset of 50 patients who were assigned to the doxy-PEP arm and found that only 56% of those participants had doxycycline detected at least one visit. And looking at the entire study, about 29% of all quarterly visits had doxy-PEP detected. And so again, doxycycline hair testing showed that even though self-reported adherence was reported to be very high amongst the group, when they actually look at metabolism, doxycycline in the hair, about 44% of those assigned to doxypep may not have taken any doxycycline during the entire course of the study. I think this calls into the question, major issues around this, and again, more work that needs to be done in proving how doxypep can work in cisgender women. I think we are looking at to see how we can develop better studies, better women-centered studies, and better understanding, how can we get a better self-reported adherence among cisgender women in such studies, and really trying to learn from some of the mistakes we made with HIV PrEP. So I will end with this slide, which is what I love talking about whenever I talk about doxypep. So I think there's striking similarities between HIV PrEP and doxypep. These are two novel biomedical interventions with significant impact in priority populations. There's concerns about antibiotic resistance and misuse, just like there was with HIV resistance a decade ago, which is born not to be true. There's a lot of equity concerns regarding utilization and uptake. And data in cisgender women are lacking, and that's really the fault of the scientific community for not being able to create better women-centric and centered studies around this. I will say, as an editorial, we do not need to go to Kenya to study syphilis in women. We do not need to go to Kenya to study chlamydia in women. Well, we should be funding that type of work here in the United States. We have plenty of prevalence and incidence here in the US of women impacted by these STIs that could benefit from doxypep, and these studies need to start being funded to be done here as well. And so what is different now, we have signals of higher interest in doxypep among Black and Hispanic Latinx men, and we really should know better. We should have really learned from our mistakes from HIV PrEP and really try to advance how we think about doxypep and how we utilize and implement it in the future. All right, I will end there with only 5 minutes for questions, Jim. I'm sorry. Stop share. Go ahead.
No, that's quite all right, Anu. And I want to thank you and everyone for just doing such a great job and covering such a huge array of research and studies and findings from these two conferences. It's a lot to take in. So I think a lot of us are going to have to sort of gestate on some of these things for a while. But this is a follow-up question for you, Anu, and I'm going to offer up an opportunity for people to raise their hand now and ask a question live in our final minutes. But J. Kevin Carmichael is wondering, are there any studies planned for cisgender women are there any planned around doxypep that you know about?
So the San Francisco AIDS Foundation did do their own doxypep talk at the World Congress, and I believe that they're starting to implement their protocol among cisgender women and trans men. I am not aware of any currently funded studies, and I've searched the Clinical Trials Network like in the past 6 months, and I haven't seen anything funding specifically for cisgender women in the United States. But if anyone on the call knows this, please share that information, because I would be highly interested if that's the case. But from my understanding, that no, the answer is still no, that this Kenya study is still the only one that I know of still ongoing, looking specifically at cisgender women.
Thank you for that. I'm also not aware, but would love to be proven wrong if there is something. I think this does call into what ties into your remarks, Anu, and sort of the theme throughout all the talks today, is that advocacy matters, community leadership matters, and all of us here have to be demanding that we have more studies focused on cisgender women and doxypep. With especially now learning that it didn't do well in Kenya due to most likely due to adherence issues. We've heard this story time and again. We have to do better. We have to do better. And the only way the research establishment does better and the only way funders do better is that they hear from us loudly and clearly, frequently. Do we have any questions? Anyone want to raise their hand and give us a final question or comment before we close? Otherwise, while we're waiting for that to potentially happen, and I know this was a lot to take in, I also, having not attended these conferences, it's like, wow, I don't even know where to begin with my own questions, but I really appreciate you all debriefing here. But maybe I'll ask everyone, all of our presenters, to go around, and you presented a lot. So let's whittle it down to, if you had to tell somebody, here is the one thing I want you to remember from the conference, the one thing in 30 seconds, What is that one thing? So think about that. I just sort of sprung this on the presenters now, but you all are bright. You'll catch up. And we're going to start. Nyaradzo, would you like to unmute and offer us your one thing?
30 seconds. So what I took from IAS, and it was like on the staircase, it was painted the message about everything that we do must be human-centered. I think once we start with human-centered interventions, options, and choice, we are good to go. It covers everything. So whether it's prevention, treatment, basic sciences, advocacy, implementation sciences, as long as we remember that there's a human being at the end of the spectrum, we'll be good to go. Thank you.
Beautifully put, Nyaradzo, and I would triple co-sign that, and I think many of our attendees would as well. I see some action happening in the chat and online. Okay, Roger, you are next. Your one thing.
I guess maybe my one thing, I'd go back to the U equals U thing, and I would just frame it perhaps in a way that I probably should have done earlier. But it's about getting access to that confidence for people who don't have the privilege that many of us here do in terms of the access to really, really precise diagnostics. So in places where diagnostics are not as precise, is there some level of reassurance that can be given? And I think that is what they were trying to do with that messaging.
Thank you kindly for that, Roger. We're going to move on to the final one thing from Charlie Peterson.
Oh, all right. I think it's how we approach communities, how we talk to them, and really that, the approaches heretofore have basically been, you need to do this, we're speaking to, or speaking at rather, we're not speaking to. There's no collaboration. I mean, yes, but there needs to be more collaboration and more empowerment of our key populations.
Thank you, Charlie, for that. And Anu, you get the last little nugget to share with everyone here today. What is that nugget?
I think the overwhelming consensus in the conference was that really that we have to think of things like a syndemic, that HIV treatment prevention goes hand in hand with STI control and vice versa. And I think, having now Dr. Marzano in leadership of the NIAID, I think it's really going to elevate how we think about STIs and not just sort of the redheaded stepchild with the sexual health world, but really making sure that we understand that, the dollars used for HIV treatment and prevention need to be shared with, the entire sexual health community. And this is all we're thinking about sexual health as a whole and not just one or the other. And it was great to be in this conference with so many like-minded folks and trying to advance the understanding of sexual health as a whole and not just thinking about HIV separately.
That's a really great way to end this meeting today. So I want to thank all of our presenters from all over the world, Nyaradzo, Roger, Charlie, and Anu. Thank you to all of the folks who registered today, over 300 of you, well over 100 who showed up live here in the so-called dog days of August, where many people are on vacation or still recovering from jet lag from Brisbane. So I appreciate you for making some time. We will be following up in the next day or so with a follow-up email that will have a link to the recording and the slides and some of the resources that have been shared here. Please engage with the Choice Agenda. If you are not on our listserv, reach out to us and happy to add you if you're interested. And I hope to see all of you at our next webinar in early September on the 6th, where we'll be focusing on people who use and inject drugs, another population that is often ignored, misunderstood, and talked at as opposed to with and by. So we hope to start to change some of that dynamic with this call next month, or be part of changing that dynamic. And I hope to see you there. So with that said, I'm going to officially close out this call. Thanks again all for being here. And I hope to see you on the listserv, on other webinars, or somewhere in between, and maybe even in real life. Take good care.
Thank you. Bye-bye now.
Thank you, Jim.